Hello, I'm Lori Fassler, and today I'm going to be talking to new medical staff, RNs, and OB techs who will be working at the Alt Memorial Women's Health and Childbirth Center about the ethics of being baby-friendly. Here are today's objectives. By the end of this presentation, I expect that you will be able to summarize the goal of the Baby-Friendly Hospital Initiative, give 2 examples of how ethical principles are related to the 10 steps of successful breastfeeding and the International Code of Marketing of Breast Milk Substitutes, and formulate 1 response that incorporates the discussed ethical principles into a conversation with mothers about the most common concerns staff voice of the 10 steps to successful breastfeeding and the International Code of Marketing of Breast Milk Substitutes. You may be asking yourself, what does it mean to be a baby-friendly hospital? The Baby-Friendly Hospital Initiative is a global program that was launched by the World Health Organization, or WHO, and the United Nations Children's Fund, or UNICEF, in 1991. This program recognizes facilities for providing and promoting optimal infant feeding and mother-baby bonding practices, with the goal of helping mothers feel more prepared to feed and care for their infants at home. In order to achieve this designation, facilities must implement and maintain adherence to the 10 steps to successful breastfeeding and the International Code of Marketing of Breast Milk Substitutes. There are 3 to 4 years of preparatory work that culminates in a site visit by Baby-Friendly USA. The designation is renewed every 5 years, and during the interim years, annual quality assessment and improvement is ongoing. Alt Memorial Hospital achieved this designation in August of 2016. I mentioned that we must adhere to 10 steps to successful breastfeeding, and those are found on this slide. These steps apply to all well-termed babies. Step 1 is have a written breastfeeding policy that is routinely communicated to staff. Step 2, all nurses and physicians working with childbearing women receive education on baby-friendly skills. The 3rd step is to inform all pregnant women about the benefits and management of breastfeeding. The 4th step is to help mothers initiate breastfeeding within 1 hour of birth. Step 5 is to show mothers how to breastfeed and maintain lactation even if they are separated from their infants. In Step 6, give infants no food or drink other than breast milk unless medically indicated. Step 7 is to practice rooming in, allow mothers and infants to remain together 24 hours a day. Step 8, encourage breastfeeding on demand. Step 9, give no pacifiers or artificial nipples to breastfeeding infants. And Step 10 is to foster the establishment of breastfeeding support groups and refer mothers to them on discharge from the hospital or birth center. After lunch, we will participate in the skills lab where we will focus on these skills of the 10 steps more closely. Is there anything on this list that concerned you? What did you think about the 10 steps? You might have thought that some of those steps sounded forceful or even bullying towards new mothers. Others thought so too in the beginning. When our journey was starting, the staff had some real concerns about the 10 steps to successful breastfeeding. Steps that specifically caused distress were steps 3, 6, 7, and 9. Here's what the staff thought whenever they were looking at these steps and the rationale for the pushback on implementation. Step 3 seemed like forced lectures about breastfeeding benefits. The nurses thought that mothers had already made up their minds about infant feeding and they would become mad or feel guilty if we discussed benefits of breastfeeding when mothers had already made up their minds about formula feeding. Step 6 seemed to the nurses that we were forcing breastfeeding on all patients, that we weren't giving anyone a choice. The mothers were given no right to choose formula feeding. And that formula just isn't really that big of a deal, and they didn't see what the problem was with allowing mothers to formula feed. Step 7 felt like forcing mothers to keep their babies with them all the time. The nurses didn't like this because they felt like the mothers needed rest, and they were able to get that more easily when the babies were taken to the nursery by staff at night for procedures and assessments. And that the moms would not like it if we did painful procedures such as blood draws in the room. They wouldn't like to see their babies crying. Step 9 seemed as if we were completely refusing to give the moms bottles and pacifiers. The staff didn't see, a lot of them didn't really believe in nipple confusion, and they felt like it was easier to bottle feed for the mothers than to learn to use a cup or alternative feeding method. Many of the people that you will be working with also had a problem with the International Code of Marketing of breast milk substitutes. Nurses were mainly concerned with the not being able to give the diaper bag gifts that came from the Enfamil and Similac formula companies. Those bags included free formula samples and coupons that we gave those bags to every mother regardless of feeding method prior to discharge. Nurses also frequently used formula as a method of service recovery. If a patient was upset about something, they would just give the mother a case of formula, and it was fine to do that because it was free at that time. The hospital did not have to pay for formula then. The nurses felt that the mothers needed formula at home just in case breastfeeding didn't go well. And they also were concerned that the moms were going to have to start paying more for formula because they were not going to have access to those free samples and coupons. To put these concerns into perspective, let's look at the principles of ethics. Then in the next slide, we'll see how they relate to the 10 steps in the code. First, we'll talk about autonomy. Autonomy is defined as the right to make personal decisions. This does not mean that mothers don't need any guidance with health decisions. Nurses do still have a responsibility to evaluate what a person needs to know and give education. Then the nurse can help the patient navigate the information and make the best decision for herself and her baby. Non-maleficence is the next principle. This is the do no harm principle. We can actually cause harm by failing to anticipate or inform of potential problems that may arise as the result of an intervention or a non-intervention. Beneficence is an act that is done for the benefit of others. This can be described as maximizing benefits and minimizing harm. Nurses sometimes think new mothers need to be protected and sometimes feel that they know better than the patient what the new mother needs. This could be seen as paternalism. In reality, there are 5 criteria for paternalism to be appropriate, and most well-new mothers don't meet any of that criteria. Veracity, or truthfulness, can come across as too blunt and impersonal. To combat this, it is suggested that the message be tailored to the patient. Additionally, our own personal experiences, thoughts, and feelings are often revealed during conversations that are expected to be controversial or emotionally charged. Nurses should use self-reflection to help understand their reactions and to keep them out of play in such conversations. Now, let's see how those principles play into the 10 steps to successful breastfeeding. First, Alt Memorial and Baby Friendly USA recognize and respect all mothers' right to autonomy. While nurses initially mistook that the Baby Friendly initiative forces mothers to listen to lectures, breastfeed, and keep babies in the room all night, it's not actually the case. For step 3, nurses are expected to give information about the benefits of breastfeeding. This is because the patient's physician may not have addressed benefits with the patient, and the family may not have had any exposure to breastfeeding in the past. Therefore, labor and delivery nurses should expose them to breastfeeding information. Nurses can give factual information in a manner that is tailored to the patient. This actually reinforces the mother's right for autonomy, as receiving information on the benefits and management of breastfeeding allows mothers to make a fully informed decision. I recommend that the nurses say something along these lines. Many organizations recommend breastfeeding, such as WHO and the American Academy of Pediatrics. It is free, easy, and has health benefits for moms and babies. Have you thought about how you're going to feed your baby? And can I answer any questions about infant feeding for you? After this, let the patient guide the conversation. If she states that she doesn't want any more information and is going to formula feed, staff should not bring it up again unless the patient requests to talk about it more. Staff does need to leave emotions, thoughts, and feelings on the infant feeding conversation at the door so as to not inadvertently influence the patient's decision. Step 6 applies only to infants of mothers whose intent it is to breastfeed. A mother's informed choice to formula feed exclusively or as a supplement to breastfeeding is honored and respected. However, nurses should counsel the mother who is requesting a supplement. Even though moms might think that one bottle won't cause any problems, research shows that even one formula feed can actually change the infant's gut flora and increase the risk of allergies and illness. One bottle or more replacing a breastfeed inhibits the production of milk immediately due to a lack of milk removal and delays the next feeding since the milk proteins in the formula take longer to digest. Failure to inform mothers of this is a breach of non-maleficence. Nurses might think that they are preventing harm by avoiding a guilt trip, but they could actually be harming the future health of the infant, the breastfeeding relationship, and cause mom more anguish down the road if she is not informed of the possible consequences. Conversation that might take place when a mother requests a supplement might include the investigation of the reasons for the supplement, offering education and support, and when the nurse is confident that the patient has made an informed decision to give formula, provide formula and educate to that decision. In step 7, this step allows the mother to keep her baby in the room for 24 hours a day. Ironically, in the past, nurses and physicians forced separation and no one thought anything of it. In fact, nurses thought that they were protecting their patients by allowing them to get more sleep or keeping moms from having to see the babies cry during painful procedures. This is an example of unnecessary and unfounded paternalism. Many studies have shown that moms and babies actually sleep better when kept together. Moms learn how to comfort and respond to their babies more quickly, and babies cry less when mom holds and breastfeeds during painful procedures. These features of a baby-friendly unit usually empowers moms and helps them to feel more prepared to parent outside of the hospital. When we examine it in this light, allowing rooming in actually minimizes risk and maximizes benefits to the new family unit and is more beneficent than separating mom and baby for the reasons previously discussed. When new mothers request the baby return to the nursery, I encourage you to investigate the reason, provide education on the benefits of rooming in, and offer to teach moms some comfort techniques. The nursery remains available for respite if mom makes an informed decision to send the baby to be cared for by nursing staff, and we respect and honor mom's autonomy in choosing to do this. Step 9 made the nurses feel like they were being non-maleficent and causing the mothers less distress and work by giving the bottle without question when a supplement was necessary or requested. Again, often as a means to avoid inducing guilt. But research and experience demonstrates that utilization of artificial nipples, including pacifiers or bottle nipples, may interfere with latch, cause pain to mothers, and decrease mothers' milk supply. It is true that mothers could potentially have a baby that switches back and forth with no difficulty, but since we can't predict which babies will have trouble and which won't, the principle of beneficence dictates that nurses explain these risks to mothers, discourage pacifiers, and suggest alternative methods of feeding supplements of breast milk or formula if the mother so requests. As usual, we will respect and honor a mother's right to make an informed decision to give an artificial nipple. Now, back to the International Code of Marketing of Breast Milk Substitutes. While nurses were used to providing diaper bag gifts to the parents and utilizing freely supplied formula for service recovery, after looking at the ethical principles nurses should adhere to, we can see that they could actually be harmful. Nurses felt they were doing good by giving patients free samples to use when breastfeeding wasn't going well, or saving the patients money by giving them free samples and coupons. In reality, evidence indicates that the provision of free samples by healthcare providers shortens breastfeeding duration, implies endorsement, which leads to brand loyalty. In addition, formula costs to parents actually increase in this case because the two formula companies that market in hospitals are Enfamil and Similac. Those two companies are the most expensive formula that parents can buy, so that even if they do use the coupons, they still are spending more by the baby's first year of life than they would have if they had utilized a cheaper version of formula. So it is actually beneficent not to provide the gift bags or use formula as service recovery. In conclusion, Baby Friendly Hospital Initiative is a program run by the World Health Organization and UNICEF that recognizes high levels of infant feeding and maternal-infant bonding support and requires adherence to the 10 steps to successful breastfeeding and the International Code of Marketing of Breast Milk Substitutes. While it can seem coercive and ethically distressing at first glance, it is actually meant to be empowering, and when reviewing through a critical eye, it is ethically sound infant feeding and bonding care. Are there any questions?